Hi everyone, this is Amanda Kellogg and I'm going to be doing just a quick overview of pulmonary diagnostics. Should only take about a half hour of your time. So let's just get started. Here are a list of some of the objectives that we will be reviewing. And we're going to start with just a real brief overview of the anatomy. We're going to start your upper respiratory tract has your nose, your nasal cavity, your rhythmoid air cells, frontal sinuses, maxillary sinuses, larynx, and trachea. And then some of the ones that we'll be more focused on is what's in your lower respiratory tract, which is the lungs, the bronchi, and the alveoli. So you start with your trachea and then it goes down into the two large tubes known as the bronchi, which then separate and distribute the air to the left and the right sides of the lungs. Then they start to become more tree-like and branch out and become smaller and smaller. And what's at the end of these are little grape-like structures, and we call them alveoli. The alveoli are little air sacs, and when the air reaches those, the oxygen then moves from the air sacs into the capillaries through their thin walls. And the carbon dioxide is released from the blood into the lungs and exhaled, and then the carbon dioxide moves from the capillaries into the alveoli. So you have that oxygen and carbon dioxide exchange occurring there. If you have too much carbon dioxide, they're not breathing enough or hypoventilating, and if you have too little carbon dioxide, they're hyperventilating. You have also your diaphragm. The diaphragm is a large dome-shaped muscle that contracts and relaxes during breathing. It separates the chest from the abdominal cavity. And then you also have your pleura, which are thin balloon-like structures or saran wrap that surrounds the lungs and allows them to move smoothly as we breathe in and out. There's the two different kinds of pleura. The one that covers the lungs are the visceral pleura, and the one that covers the chest wall are the parietal. And then you have the pleural space in between that has that small amount of fluid, and the fluid is moved in throughout the lungs via the lymphatic system. And the lymphatic system is very similar to blood vessels. They move the fluid throughout our body to help get rid of the foreign objects like bacteria, viruses, or asbestosis fibers. So, what are pulmonary diagnostics? They're a group of tests that measure how well the lungs take in air, how well they release air, and how well they move gases from the air to the body. They can be performed in hospitals, medical offices, or even the patient home. Pulmonary diagnostics can be done for several reasons. Some are like disease states, such as asthma, bronchitis, or emphysema. If there's an unknown cause of shortness of breath, if the patient is having surgery and they need to ensure their lungs are working properly, if there's an effect of certain workforce chemicals being investigated, such as like a Dow employee being exposed to a certain chemical, if they're using certain breathing treatments like albuterol, they want to test the how it's working. Or if they want to gauge a disease progress, such as like with COPD, asthma, or bronchitis. And then also to establish baseline operations. A pulmonary function test takes about 15 minutes for an adult and about 15 to 30 minutes for children, and 45 minutes if you are doing like a pre and post bronchodilator testing, or a full hour if you're doing a full set of PFTs with the diffuse capacity of lung for carbon monoxide testing. And usually about 5 years of age is the youngest that a kid can be to cooperate with the procedures of pulmonary function testing. The next thing we're going to do is review the terms that were in the objectives. So I'm just going to go through these very briefly, and if you need to go back and review them, you can. Tidal volume is the lung volume representing a normal volume of air displaced between normal inhalation and exhalation when extra effort is not applied. In a healthy young human adult, tidal volume is approximately 500 milliliters. We measure this to get a baseline of patients' lung functioning during normal rest. A change could point to either an abnormality or change in a lung function. Minute value. Minute value is the volume of gas inhaled or exhaled from a person's lungs per minute per inspiration. In a healthy young human adult, minute volume is approximately 5 to 8 liters per minute. We check this as it is important in respiratory medicine due to the relationship to carbon monoxide levels. Vital capacity is the maximum amount of air a person can expel from the lungs after a maximum inhalation. It is equal to the sum of inspiratory reserve volume, tidal volume, and expiratory reserve volume. Normal vital capacity is 3 to 5 liters. It can help differentiate between different causes of lung disease. So in restrictive lung disease, the vital capacity is decreased. In obstructive lung disease, it is usually normal or only slightly decreased. Functional residual capacity, or FRC, is the volume of air present in the lungs at the end of passive expiration. At functional residual capacity, the elastic recoil forces of the lungs and chest wall are equal but opposite, and there is no exertion by the diaphragm or other respiratory muscles. We test this because a lower or elevated FRC is often an indication of some form of respiratory disease. For instance, in emphysema, the lungs are more compliant and therefore are more susceptible to the outward recoil forces of the chest wall. Emphysema patients often have that noticeably broader chest because they are breathing at larger volumes. In healthy humans, the FRC changes with body posture. So with obese patients, they will have a lower FRC in the supine position. Total lung capacity is the volume in the lungs at maximum inflation. This is usually about 4 to 6 liters in a normal adult. We test this because it can be increased or decreased based on a disease state. Forced vital capacity is the volume change of the lung between a full inspiration to total lung capacity and a maximal expiration to residual volume. The measurement is performed during forceful exhalation. The preceding maximal inhalation need not be performed forcefully. We do this because it is used to diagnose lung disease and also determine respiratory involvement in neuromuscular disease. Forced expiratory volume is the measure of how much air a person can exhale during a forced breath. The amount of air exhaled may be measured during the first, second, or third seconds of the forced breath. These are referred to as FEV1, FEV2, or FEV3. We do this for the diagnosis of obstructive lung diseases such as asthma and COPD. A person who has asthma or COPD has a lower FEV1 result than a healthy person. So we can also look and see how well medicines are used to improve breathing and if they are working, and to check lung disease if the lung disease is getting worse. Decreases in the FEV1 value may mean the lung disease is progressing. Forced expiratory flow is the flow or speed of air coming out of the lung during the middle portion of a forced expiration. We look at this because it can help to diagnose a lung issue and help show if the disease is worsening. Peak expiratory flow is the maximal flow or speed achieved during the maximal forced expiration initiated at full inspiration. It is measured in liters per minute or in liters per second. It is used to assess a patient's asthma control level and is compared to baseline normal control values. It can often be part of the action plan with zones of control. This here is a stepward approach to interpreting the pulmonary function test and to determine whether there's a need for further testing, and how to use the pulmonary function test to formulate differential diagnoses. So we're going to talk now about the interpreting pulmonary function test. We're going to talk about it in steps. The first step is to determine if the FEV1 and the FEVC ratio is low. The first option is to follow the GOLD criteria, which uses a cutoff of less than 70%. The second option is to follow the ATS criteria, which is to use the lower limit of normal as the cutoff for adults. The second step is determine if the FVC is low. This table here kind of summarizes the first two steps of the PFT interpretation. So as you can see, we can look at the FVC and the FEV1 ratio, see where they are at, and what the suggested diagnoses are. The third step is to confirm the restrictive pattern. If the patient's initial PFT results indicate a restrictive pattern or a mixed pattern that is not corrected with bronchodilators, the patient should be referred for full PFTs with a DLCO. The DLCO is a quantitative measurement of gas transfer in the lungs. Diseases that decrease blood flow to the lungs or damage alveoli will cause less efficient gas exchange, resulting in a lower DLCO measurement. And we'll be talking some more about the DLCO later on. The fourth step is to grade the severity of the abnormality. If an obstructive defect or restrictive pattern or a mixed pattern is present, this is where it'll show up. And this is the ATS system for grading the severity of the PFT abnormality. So this is a table that does step 4. Step 5 is determining reversibility of the obstructive defect. If the patient has an obstructive defect, the physician should determine if it is reversible based on the increase of the FEV1 or the FVC after a bronchodilator treatment. The PFTs show a mixed pattern, and if FVC corrects to 80% or more after bronchodilator use, it's likely that the patient has pure obstructive lung disease with air trapping. Step 6 is bronchoprovocation. If a PFT results are normal, but the physician still suspects exercise or allergen-induced asthma, this is the next step, and includes the methacholine challenge, a mannitol inhalation challenge, exercise testing, or sometimes some other testing, which we'll talk about some of those other testings later. Step 7 is to establish differential diagnosis. The PFT results have been interpreted. The broad differential diagnosis should be considered. And step 8 is to compare current and prior PFT results. If the patient's prior PFT results are available, they should be compared with the current results to determine the course of the disease or effect of treatment. And again, this was all summarized in that nice diagram back in the beginning. Pulmonary diagnostic tests that we'll be talking about include spirometry, lung volumes determination, diffuse capacity of lung for carbon monoxide, assessment of respiratory muscle strength, a pulse ox, pneumothocholine challenge testing, cardiopulmonary stress testing, ABGs, and exhaled nitric oxide. The first one we'll talk about is spirometry. Spirometry is used to establish baseline lung function, evaluate dyspnea, detect pulmonary disease, and monitor effects of therapies used to treat respiratory diseases, evaluate respiratory impairment, evaluate operative risk, and perform surveillance for occupational-related lung disease. Two choices are available with respect to bronchodilator and medication use prior to testing. 1. The patient may withhold all the oral and inhaled bronchodilators to establish a baseline lung function and evaluate maximum bronchodilator response. Or, if your patients aren't able to come off of those to test this, and we'd be worried about bronchospasm during the test, they may continue taking their medications as prescribed. The test itself, the patient takes the deepest breath they possibly can. The patient then exhales into the sensor as hard as possible for as long as possible. This is usually about at least 6 seconds and requires a computer integrated system for result graphing and data collection. And we are going to watch just a couple minutes of this video. Because it shows them performing a test and how to talk her through it. And it's one of the handheld testing systems.
Okay, how old are you?
27.
27. How tall are you?
154 centimeters.
54 centimeters. Okay. Do you smoke or have you ever smoked?
No.
No. And do you suffer from asthma?
No.
No. At first you take on this nose clip, then I will give you this device. You take it like this, you inhale to the max, then you take the mouthpiece into the mouth, and then you exhale completely. There are two important aspects. Firstly, you have to exhale as fast as possible in the first second, and secondly, you have to exhale completely, so that you make sure to get all the air out of your lung. Okay? I'll support you with this. I'll tell you when to stop, and we approximately have to do it 3 times, 3 to 4 times. Okay? So put on the nose clip, please. Okay, here we go.
Okay.
Yep. Okay, keep going, 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 keep going. Perfect. Okay. Could you focus on inhaling a little more, if possible, and on the other side, exhaling a little longer?
Right.
Okay. Do you want to have a little break, or?
Yes.
Okay. So, you ready?
Yeah.
Perfect.
Okay, that's all we're going to watch of that. But you get the point of how the spirometry is done. The next test we're going to talk about is the lung volumes determination, which is used in the evaluation of suspected restrictive lung disease and the evaluation of hyperinflation. Patients should, if they use supplementary oxygen just prior to a nitrogen washout test, may cause an underestimated of the FRC unless the initial exhaled nitrogen is considered in the calculations. So just keep in mind that if they're using oxygen, they need to consider what the effects of that will be on it. The functional residual capacity is expressed in liters. This is the volume of gas in the lungs at the end of an average resting expiration. It is comprised of an expiratory reserve volume, the volume of gas that can be voluntarily exhaled beyond the functional residual capacity, and the residual volume. The total lung capacity can then be calculated by adding the residual volume and the vital capacity, or to the vital capacity. Obstructive lung diseases, particularly emphysema, result in an increase in the RV and the RV to TLC ratio. Increased body weight due to an increased fat causes an increase in chest wall elastic recoil, which favors the lower end expiratory lung volume, resulting in less hyperinflation for any degree of airflow obstruction. And reduced TLC is the hallmark of restrictive lung disease, such as interstitial lung disease, atelectasis, and pneumothorax, consolidation, edema, and fibrosis. The next set of tests we're going to talk about is the diffuse capacity of lung for carbon monoxide, and this is that DLCO that I said we were going to hit on, which is the measurement of ease of transfer of carbon monoxide molecules from the alveolar gas to the hemoglobin of the red blood cells in the pulmonary circulation. A patient should refrain from smoking for several hours before the test. Alcohol vapors can also have an effect on accuracy for some of the fuel cells types of the carbon monoxide analyzers. Thus, alcoholic beverages should be withheld for at least 8 hours prior to the test. Reported parameters typically include the DLCO and the diffusing capacity of the lung alveolar volume, the average inspiratory vital capacity, or IVC, up to reproducible measurements, and the average calculated alveolar volume, or VA, and hemoglobin corrected and carboxyhemoglobin corrected values. So for interpretation, because the DLCO is directly proportional to alveolar volume, non-pulmonary processes that reduce the TLC cause reduction in the DLCO. Disease processes such as a lung resection, thoracic cage abnormalities, or small lungs can do that. Reduced DLC and a reduction in the diffusion capacity of lungs to the alveolar volume ratio suggest a true interstitial disease such as pulmonary fibrosis or pulmonary vascular disease. But a normal DL to VA may not be sufficient to rule out the presence of a parenchymal disease. Anemia produces a vital reduction in pulmonary capillary blood volume that causes a reduction in DLCO that can be adjusted mathematically for reduced hemoglobin. The DLCO may be reduced temporarily in a variety of disorders such as pneumonia, interstitial infiltrative disorders, and alveoli proteinosis. So just some diseases that can cause it to be low. Assessment of respiratory muscle strength is an assessment that allows for us to look at the failure, like of restrictive lung disease and respiratory muscle strength. And some values that are given are MIP and MEP. For determining the MIP, patients breathe through a flanged mouthpiece with nose clips in place. They're instructed to exhale to the RV. At the RV, the valve or shutter is closed, and then the patient is coached to inhale as forcefully as possible. The maximum pull should be maintained for about 1 to 2 seconds. In the MEP, patients breathe through the flanged mouthpiece with the nose clips in place. Patients are instructed to inhale to TLC At TLC, or total lung capacity, the valve or shutter is closed and the patient is coached to exhale as forcefully as possible. The maximum push should be maintained for about 1 to 2 seconds. Initial maximum positive pressure can not be maintained for a full second, then the measure is ignored. As many as 10 efforts are needed before there's consistency. And then for consistency, they need to have 2 measurements within 10% of the highest measured pressure. And so because of that, the respiratory muscles can easily become fatigued if they're doing that 10 times in a row. Or if there's like a neuromuscular disease such as like ALS present, the fatigue may be set in before consistency is achieved. If the range of normal values is broad, suggesting a wide variation in respiratory muscle strengths among the normal values. So then we have our pulse ox, which all of us probably are fairly familiar with. We use pulse ox to assess oxygen desaturation. The value that's given is an SpO2. And for interpretation, we look at if they're using oxygen, if they have anemia, and their PCO2. Documentation for a pulse ox should include what kind of pulsometry was used, what probe type was used, where the probe was placed, the heart rate, and the SpO2 reading at rest. When obtaining the reading during exercise, the type and intensity of the exercise should also be documented, along with the heart rate at the end of the activity should be reported. ABG should be considered if there's ever clinical suspicion of hypoxemia, even when the pulse ox shows a value over the 88% threshold. Disadvantages of a pulse ox include that it cannot be used to assess oxygen delivery, such as anemia or adequate ventilation. Next one we're going to look at is the methylcholine challenge testing, which is used in the diagnosis of asthma, confirming diagnoses of asthma, documenting the severity of hyperresponsiveness, and follow changes in hyperresponsiveness. Patient prep should include holding of certain medications such as short-acting beta agonists, long-acting beta agonists, oral beta agonist, short-acting methylexins, or long-acting anticholinergics, your chromial sodium, and antihistamines. Withholding of oral or inhaled steroids before methylcholine has not been shown to necessarily have an impact, but it may. Results are presented as both a table of spirometry parameters for each stage of the challenge and as dose-response curves plotting the fall in the FEV1 against the methylcholine concentration. The reporting of the PCO2 concentrations causes a 20% fall in the FEV1 from baseline. It is usual method of expressing the result as being a positive test. So the 20% fall in the FEV1 from the baseline means it's positive. Typically, they look at a 35% fall specific airway, or the SEGWA, to denote the presence of airway hyperactivity when technically good spirometry cannot be obtained. Failure to demonstrate bronchial hyperactivity does not totally exclude asthma, particularly asthma triggered by occupational exposure to chemicals. Pulmonary, the next one is your stress test, which I'm sure most of us have had some exposure to that. So it is used to evaluate dyspnea that is out of proportion to the findings on static pulmonary function test. Preoperatively, for the evaluation of operative risk when lung function is compromised or removal of lung segments is contemplated, evaluation of disability, identification of exercise-induced asthma, and evaluation of therapy. The following parameters are measured or calculated on breath-by-breath basis and include those listed. The assessment of normal work capacity is made by the evaluation of peak oxygen uptake. The normal value of oxygen uptake is based on sex, age, and weight. The predicted peak VO2, or peak oxygen uptake, is determined by the patient's age and sex. This value can be further refined for sedentary individuals by a three-step process that adjusts the prediction value up or down based on the confirmation of the patient's weight and their ideal body weight. And ABGs. ABGs are used to evaluate ventilation, oxygenation, and acid-base status. The values include those listed and can be measured, and then the ones that can be calculated. Low levels of arterial oxygen can be attributed to one or more of the 5 categories as follows, and that is the ventilation perfusion, or VQ mismatching, alveolar capillary diffusion limitation, hypoventilation, anatomic right and left shunts, and low inspired oxygen partial pressures or altitude. And then just a brief little graph on respiratory acidosis and alkalosis that goes along with ABGs. I'm sure we're all familiar with that. And our last one, our lung volumes determination, which are easy, non-invasive alternative to direct sampling of a lower airway by sputum induction, lavage, or biopsy. The volumes given are in a fractional concentration of exhaled nitric oxide, and they're interpreted by exhaled nitric oxide as a clinical marker of the disease activity, particularly in asthma. And there's 2 ways of measuring it. You can measure it online or offline. Online is when the patient exhales directly into the measuring device, where offline is their exhaled breath is collected into a sample bag and then for later measurement. And usually offline is used for epidemiology and for research basis. The online device typically uses a flow limiter to keep the sample flowing at a fixed flow range, which is typically 50 milliliters per second. The standardization of the measurement technique has allowed the development of normal ranges and standard interpretation schemes in online measurement. And that is it for the lecture on pulmonary diagnostics.